Thank you very much, and thank you all for being here. I realize I am incredibly rude and never introduced myself, which is terrible. I'm so worried about the tech. My name is Wendy Book. I'm the current president of the American Partnership for Eosinophilic Disorders, and I've been involved with the organization since 2004. APFED represents a whole host of eosinophil-based diseases, all of them rare. Hypereosinophilic syndrome, as those of you living with it know, is quite rare. It is my pleasure to introduce our next speaker, Dr. Gerald Gleich, and I could spend the whole day talking about Dr. Gleich and his contributions to not only eosinophil science, but to the patient community. He has been an advocate for the patient his entire life, and he is dedicated, one of the most dedicated physicians that I've had the honor of working with. He has numerous publications, I don't know how many now, well into the hundreds, maybe 1,000 by now, on eosinophil-based diseases, and has contributed significantly to the literature. He speaks at many of these meetings, and he personally cares for many patients with hypereosinophilic syndrome. So Dr. Gleich, it is a great pleasure to have you here speaking to us today. Get your slides up.
Oh, good. Is there a pointer?
No pointer, but let me see if...
No pointer.
No pointer. I don't think that goes there. You want me to point?
No. Well, thank you, Wendy. My presentation deals with hypereosinophilic syndromes then and now, and I noted it's a perspective piece. You know you're getting senior when people want you to talk about history, I fear. So what I'd like to do is to lead you through the evolution of our knowledge regarding certain aspects of eosinophils, but more particularly eosinophil-associated diseases. And to do that, I have to, let's see how we doing here. There we go. Disclosures. I have many disclosures, but really none of them are truly pertinent to what we're doing today. I will talk about many pharmaceutical agents, some approved and some not approved, because this goes back in history. So I want to go back to 1879 when Paul Ehrlich, then a medical student, took eosin, a drug that had been developed by the dye industry, and the dye industry in that era was concerned with clothes. I think especially skirts and blouses. Guys, I'm sorry. And Ehrlich had the genius to recognize that these dyes were, in essence, chemical probes that he could utilize to dissect biology. So he took the dyes and stained blood, and one cell emerged as intensively binding eosin. And Ehrlich, as a Greek scholar through the German education system, no doubt, referred to it as the eosinophil, in other words, loving eosin. You might ask, why does it love eosin? Eosin's an acidic dye. The eosinophil and its granules are they're loaded with basic proteins. Ehrlich also established means to quantify the numbers of cells. You might say that people had recognized eosinophils before Ehrlich, but what Ehrlich did was to establish a technology that was reproducible and easily transmissible so that others could adapt that technology. So parasitic diseases and asthma, and he also established methods to quantify, as I mentioned, and in certain cutaneous diseases, these eosinophils were shown to be elevated. Those of you who have a historical bent can go on Amazon and can search under Ehrlich, and you actually can buy his book, The Histology of the Blood, published in 1900, which gives you a somewhat different view of the world. Now, as a function of Ehrlich's work, 5 blood cells emerged. The eosinophil, of course, at the top and in the center, the basophil, the monocyte, the lymphocyte, the neutrophil. And as I said, these cells could be quantified so that now we had numbers of blood cells, percentages, which can be readily determined. Blood counts were likely performed in Germany before the turn of the 20th century, in the late 1800s. And it seems that sometime after 1900, blood counting was widely practiced. I joined the staff of the Mayo Clinic in 1965, and I still remember very vividly there was a room as big as this room, well, maybe not quite this big, with benches where people were had microscopes and they were reading, I should say, analyzing blood smears and counting the number of the different white blood cells. By 1920, it said the modern era of hematology began. That's what you read in textbooks of hematology, which I was surprised didn't give much credit to Paul Ehrlich, even though his work seems to have laid the foundation of hematology, namely the enumeration of blood cells. Automated cell counting came in sometime in the 1970s, likely, and at this stage of the game, getting a complete blood count and differential, I had to show it to one of my patients the other day. There's about 20 specific pieces of information there. So the first case of HES that was likely seen in this country was reported by a group in 1955. So in the slides that I'm going to show you, I'm going to show dates. These dates are sort of milestones. In 1955, this was likely the first case, and the article referred to Loeffler's endocarditis parietalis fibroplastica. And what Loeffler, who was Swiss and reported this, I think in around 1935, what Loeffler reported was a cardiac disease in which there was a proliferation of tissue which altered the beating of the heart by filling up the cavity, such that there was diminished room for blood to be pumped. This was likely the first case of HES. This shows the changes that happened, and I think you can see this is the left ventricle, and it's gradually being filled up with this Loeffler's fibroblastic deposition. I'll come back to that. This gets to be called a variety of other names. I'll not spend time with that. A hallmark, though, was the designation of the term hypereosinophilic syndromes by Hardy and Anderson. Hardy and Anderson were two specialists in internal medicine in Albuquerque, New Mexico, and they identified 3 patients in their practice. And then they reviewed the literature in this paper in 1968. The patients had striking eosinophilia. They had cardiac or pulmonary symptoms. Their spleen and liver were enlarged. 2 had marked pruritus, itching. And they felt that these patients were part of a continuum associated with increased eosinophils, and thus coined the term the hypereosinophilic syndrome. Now, if you look at these patients, you can see that, well, you can't see very well. I can't see. Can you focus there, or do I need to focus my eyes? In any event, what that says is that the patients had marked involvement of the heart and the formation of what's called a mural thrombus. What does that mean? Well, mural wall, and the thrombus is a blood clot. So these people formed blood clots which stuck to the heart. This in turn shows a patient's heart that regrettably I was involved in his care, and I'll lead you through the pathology because this is what Hardy and Anderson and what the earlier folks had been talking about. First of all, there are vegetations that involve what are called the cordy tendinae, these little strings of fibrous tissue, and those strings, cordy tendinae, anchor the valve. And the valve we're talking about here is the valve between the left atrium and the left ventricle, the mitral valve as it's called. And when that gets involved, blood does not get pumped efficiently because it flows back from the ventricle into the atrium. But perhaps more critically is the formation of this massive thrombus in the left ventricle, which then ends up occupying space. So there's less space, less volume for the heart to pump. And thus this patient died of cardiac failure. What does this look like when one has tissue? In this particular patient, we did have tissue. And to the left is the part of the heart that was at the cavity, and that's filled with the thrombus, the blood clot. If I walk away from the mic, I got to use this, okay? It looks like a club, but I won't. A little bit further in to the structure of the heart, there's an organizing thrombus, and then further up, there's a rich infiltrate, which is loaded with eosinophils. I and my colleagues, when I was at Mayo, were very interested in understanding how this happens. And one of the first things that happens in the development of this kind of a process is the adherence of eosinophils to the lining of the heart, the endocardium, as it's called. And those eosinophils release granule proteins, and one of the granule proteins we followed was called the major basic protein because it's the predominant constituent of the granule. And when you take this kind of a specimen and you ask where are the granule proteins, the tissue is essentially painted with the granule proteins, especially the major basic protein. Is that important? Well, perhaps. I don't think we can be certain of this, but the major basic protein actively activates? Yes, indeed. It activates platelets, and it's as effective as thrombin in activating platelets. So you get a molecule out in tissues that have that capacity. You can understand how it might further the process of deposition of a clot. Hardy and Anderson did concern themselves with treatment. In the earlier case, they didn't really worry about treatment, but by 1965, there were some drugs that one might be able to use. They tried 6-mercaptopurine, they tried prednisone. These drugs were not effective in the treatment of these patients. They curiously found that diphenhydramine was effective, and those of you who are with a chemical bent will realize that diphenhydramine is Benadryl, and you can buy it over the counter. Needless to say, it has not survived. I think there's one other point I should make. These patients that I'm talking about probably had what we now would call eosinophilic leukemia. And as Dr. Presson pointed out, we would use that drug, Gleich, or Imatinib, to treat them. I can't be certain of that, but the pathology is so characteristic that one wonders. Now, the next key development, roughly 10 years later, was by a group at the National Institutes of Health, Michael Chusid, but led by Dr. Shelley Wolf. And if there were time, I'd love to tell a little story about Shelley Wolf, but I'll spare you that. Suffice to say, what this group did was to establish diagnostic criteria, a critically important thing to do. And the diagnostic criteria are those which many of you are aware of, namely an elevated level of blood eosinophils, and they struck the number 1,500. It's remarkable, even though in the early part of this century, we went back and a group of us kind of fussed about this. Fuss, I think, is the correct word, because we didn't see a better number. So their number struck in 1975 persists today. The absence of other diseases such as a helminth, a worm disease, parasitic infection that could explain the disease, and finally, evidence of organ involvement. And I'll come back to that in a bit more detail. So as part of this article, what Chusid and Shelley Wolf did was to review the literature. So if you want to get a picture of what this area looked like, you can read their paper. The references are in my slides. They found 57 cases in the literature that they reviewed. Those cases spanned almost 5 decades. And they looked at what was utilized for treatment. And to make a long story short, they didn't see anything that was available roughly 1975 as an effective treatment. They looked at agents utilized that we still utilize, of course, glucocorticoids. They looked at drugs utilized to treat malignancy, 6-mercaptopurine, chlorambucil, radiotherapy. They looked at other agents such as cyclophosphamide. They looked at agents affecting parasitic diseases. None of these were effective. They also were concerned with how these patients survived. And if you look at the survival of the patients, actually this is the mortality. And as you can see, that line is going in the wrong direction, so that in 3 years, roughly, over 90% of the patients had died. So in 1975, this was an ominous disease to get. But again, I think it's fair to say that a lot of these patients, if not most, likely suffered from what we now would recognize as eosinophilic leukemia. In this slide, which you're going to have trouble reading, in fact, I have trouble reading from this vantage point, they looked at the various treatments, they listed the various treatments that they have available, and these treatments were really nothing spectacular, with one exception, and that is they first had hydroxyurea. Hydroxyurea is a medication which was initially used to treat leukemia, and only gradually did it come into use in patients with eosinophilia. The potential for that drug was not lost upon Dr. Wolf and his colleagues, and in 1978, Dr. Perillo and even Dr. Fauci were on a paper which described additional results. And these additional results in 26 patients utilized hydroxyurea in many of them, with a much improved prognosis. The results of this study are shown here. The survival of the historical patients, the black dots, I've already shown you, and that's discouraging. The survival of their new series, treated at the National Institutes of Health, is shown on the open circles, and as you can see, that's far improved. In 3 years, it looks like about 90% are surviving, as opposed to 90% dying in the historical series. Now, and I'm sure everyone in the room appreciates that these historical controls are flawed, but it was the best they had at the time. So another drug that came into use was interferon, and that was used in a few cases, and my colleague Joe Butterfield and I reported 6 cases in around 1994. So this was a new agent, if you will, a new kid in the block, and we used this in a series of patients, and 5 of these patients really did quite well with interferon. Now, some in the room have actually had more intimate experiences with interferon. Not exactly a happy drug to use, although I have to say that one of my patients who I started treating around 1980 and started on interferon in the 1990s is still receiving interferon with really quite wonderful results. So that on occasion, this drug can be very helpful and well tolerated. On the other occasions, it's not so well tolerated. And another of my patients with what probably is something akin to eosinophilic leukemia developed a whole series of difficulties, including reduced thyroid function and also a clinical picture looking like Parkinson's disease. So this is okay, but not perfect. We, in the 1990s, while I was still at Mayo, had the advantage of taking these drugs then into utilizing them in a group of patients that came to our attention were patients who had mucosal ulcerations. And if we designed a room to impede illustration of what I'd like to show you, we couldn't have done it much better than this room. But be that as it may, I think you can perhaps, not easily, I was going to say you could glean the ulcerations, so I'll go quickly. That one should be obvious. And then it could involve the genitals as well. And we had a group of these patients that myself and my colleague, actually my wife, Kristen Leiferman, and I investigated in the mid to late 90s. And the eosinophil counts on these patients are illustrated in the yellow, and the red circles indicate, the red crosses, I should say. Shouldn't really be red cross. That's a hopeful sign. This is a bad sign because all those patients died. They died in spite of the fact that Shelley Wolf and his colleagues had reported how good, effective the treatments that they had devised. We didn't quite agree with that, although some of the patients did do well when treated with alpha interferon. A key development, though, was the treatment of the hypereosinophilic syndrome with Imatinib mesylate. Why was that a key development? It was a key development for 2 reasons. First, and perhaps most importantly, the patients treated with Imatinib had marvelous improvement in their disease. So this is a report that I and my colleagues put together in actually it was in the late 90s and then in the early part of this century of, I think it was 5 patients, 4 men and 1 woman. The 4 men had spectacular improvements. They had been treated with hydroxyurea, with prednisone, with alpha interferon, and within a few weeks they were able to stop all of these medications while only receiving Imatinib. So as Dr. Preston says, this was a promised land of sorts. The second reason that this was critical, a drug was being utilized which had a molecularly defined target. So the response of these patients told us that these patients had, in essence, a kinase disease. And it took a relatively short time for that information to be fully developed. And this is a paper in the New England Journal in 2003. And if you're getting the sense that the advances are coming more quickly, I think that's true. In other words, if you look back in history, 1935, Loeffler, 1945, 55 actually, the group reporting on a case. And then little by little, there's more advances, but now they're coming more quickly. This was a key advance because what Jan Kool's and Gary Gilliland at the Harvard School discovered was that there was a new molecular target because a piece of the DNA had been lost, bringing together two parts of the DNA which ordinarily are not together. And this resulted in the production of a new protein, a tyrosine kinase, which luckily Imatinib or Gleich has remarkable specificity. So that this drug then became key. And in fact, this drug initially approved for the treatment of chronic myelogenous leukemia, CML, was quickly approved on a relatively small number of series because the results were so dramatic. So one, we had a new treatment, remarkably effective. The patients went on this drug and stopped having to use these difficult drugs like interferon alpha. They can get off prednisone. They don't need hydroxyurea. Two, this provided a molecular insight. And three, it provided a definition. So now we can define patients that fell into this category. In the past, I saw a lot of these patients. Now those patients at our institution are treated by my colleague Michael Deininger in hematology. Do I see the patients? On occasion, but Mike is quite good. So another development coming quickly on the heels of that Imatinib discovery was the utilization of mepolizumab. Now, most of you know what mepolizumab is. It's a monoclonal antibody that neutralizes the effect of interleukin-5. And it was back in the 1980s that interleukin-5 was discovered as a key molecule driving eosinophil production. So most of us in the room have interleukin-5 as a key molecule, keeping our level of eosinophils increased. I shouldn't say increased, but established, because there are normal levels. And if you give me antibodies to interleukin-5, mepolizumab, my eosinophils will drop, as will those of the rest of you. This study showed that you could spare prednisone in these patients. Now, these patients now represent a better Augenblick, a better look at what we have now, because none of the patients with the new kinase, none of the patients who would have been responsive to Imatinib were included. So we've now segregated out that group of patients. They're getting Imatinib. And we're left with a group of patients with what we term the hypereosinophilic syndrome now. But these patients do not have eosinophilic leukemia. One can argue, in fact, that our current definition of HES might be critiqued. Why? Because it was evolved at a time when the great number of patients actually had eosinophilic leukemia. Presently, we're not concerned with those patients. Well, we are, but not in the way that we're seeking new drugs because Imatinib is quite effective. Rather, we now see patients with eosinophilic esophagitis, and those patients commonly do not have marked peripheral blood eosinophils. Should they be part of HES? One can make that case. I'd like to quickly switch then to a paper by Dr. Gleich's group, which took advantage of the ability to accumulate 188 patients. And this was 2009, so most of these patients did not respond to Gleevec. Some did, as I'll show. What kind of manifestations did they have? Well, as you can see, skin manifestations were very common. What kind of treatments were applied? Well, many of the treatments that we've talked about, on the left at the bottom, prednisone, at the right at the bottom is anti-IL-5, and then other drugs would be hydroxyurea, alpha interferon, even Imatinib. They still had a few patients who were treated, and cyclosporin. Occasional patients will respond to Imatinib, even though they don't have the kinase. So it's worthwhile doing a trial. Of the patients that responded nicely, the ones to anti-IL-5, the ones treated with Imatinib, of course, but not of course, because these patients were unusual. And of course, prednisone is still useful. We now, though, are approaching a more interesting time. For example, benralizumab, Fasenra, I've forgotten the trade name, abolishes eosinophils. It ablates them. And in studies that have been done with biopsies in asthma, not only are blood eosinophils diminished. I recently had a patient in whom I did a blood count on. Patient's getting benralizumab. The blood count counts about 20,000 cells. There were no eosinophils. I thought to myself, that's got to be a mistake. So I repeated the complete blood count. Sure enough, the second one confirmed the first. This patient had 0 undetectable eosinophils in his blood. Biopsies of tissues showed that about 95% of tissues are depleted of eosinophils. So we've gone to perhaps a new era in which eosinophils are no longer present in tissues. Do we need eosinophils? A group of us got together and looked at that question. Dr. Gleich, Peter Weller, and the late Jamie Lee. Dr. Lee was a murine specialist. That is, he was a mouse doctor. He proudly proclaimed his murine origins and would trot his mice out if he could in front of you. He created a mouse. He created a mouse with no eosinophils, 0. Was this animal healthy? And the answer is that in the context of the quarters in which the mice are kept, they're quite healthy. What does that mean? That means we don't need eosinophils, at least for mammalian development in that species. Do we need it in humans? Well, I don't think we know. But when I and my colleagues reviewed this, we could not identify any characteristic abnormality associated with eosinophils. So today we're going to look at current treatments, but I think it's fair to say we're at a new era. The patients with HES in the literature and the ones that Dr. Wolf and his colleagues worked at, and earlier Hardy and Anderson, these patients likely had eosinophilic leukemia. We're dealing with a different group of patients now, in the sense that the dramatic cardiac findings ordinarily are not as likely, although they can occur. So we're at a new time, and this should be regarded as an optimistic time. To deal with that, I should comment about Steven Pinker's book, Enlightenment Now, which Bill Gates says, what does Bill say? He says, best book I've ever read. Why are we in the best of times? Well, this is life expectancy as a function of time from 1771 to 2015. And as you can see, we're all living longer. And that's not too bad, I think. The increase, however, is probably due to a major degree to our vastly improved survival of babies. My grandmother had 10 children, 3 survived, 2 died in 1918 in the Great Influenza, and 5 died in infancy, and I'm not quite sure of what they died of. They got sick. So babies survive, life expectancy goes up. Here is maternal mortality, and as you can see, that is dropping. Here is actually the number of deaths deaths from automobile accidents. That's going down. Sadly, however, I didn't show the curve for the opiate epidemic because that's, I fear, going in the opposite direction. On the other hand, fake news, as some people have talked about. So how many people read about the wonderful environment in Austin, Texas? What a wonderful place that is to live. Not a soul saw it. All you read about was the bombs. What do we read in the newspapers? Gloom and doom. That's what they live by. So it's not fake news, but that's what the newspapers report. It would not be fair for me not to make acknowledgments and to acknowledge my close colleague, Dr. Chris Leiferman. This goes back and shows an earlier day in 1976 when we were married, and you have to be careful who you marry because now we have a whole cabal of people. Thank you for your attention.
Well, thank you very much, Dr. Gleich. I can tell you for those of us on the patient side, we often feel like we're waiting for science and the medical community to catch up with our needs and where we're at with these rare diseases. And your talk gives me great hope for the very near future that we're going to see some therapies coming about.